Hi, this is my new video in which I will be talking about diffuse large B cell lymphoma DLBCL, of which we have been talking in our previous videos. So yes, what is the origin of diffuse large B cell lymphoma? The origin is from a naive B cell. It can be a naive B cell, it can be a centroblast, and it can be a centrocyte also. Now you will understand why is such is that. I mean, why is that? So when we go to the pathogenesis of DLBCL, then when it is a case of chronic lymphocytic lymphoma or chronic lymphocytic leukemia or small lymphocytic lymphoma, what happens is that the mutated naive B cells there, when they accumulate even more mutations like TP53 or Notch1 mutations. Notch1 mutations are those mutations which are responsible with which keep that when this Notch1 is there, it is a transcription factor which is required for a differentiation of the blast precursors. But still, if this is mutated, then it even helps the cell to be an undifferentiated state. And if it is arising from the centroblast, what happens is that in most of the cases, in 30 to 40% cases, there is overexpression of the protein BCL6. Just like I told you that there is expression of CD10 and BCL6 protein, normally in the germinal center cells, which include centroblast and centrocyte. So what happens is that when there is somatic hypermutation going on, or the DNA is changing to produce the antibody, what happens is that there is a mutation which can obviously lead to increased expression of BCL6. And why does BCL6 cause that? See, BCL6, just like I told you, it did not only suppress antibody production, it was also required for the maintenance of an undifferentiated state, because centroblast and centrocyte, though I mean, you require that undifferentiated state. And also we had to suppress TP53, right? Because if we are making DNA changes, then obviously TP53 will interfere us. So we need to activate BCL6 for that. And even after having the BCL6 mutation, overexpression of BCL6, if we get a mutation in the MYC gene. MYC gene is actually a proto-oncogene which is required. I mean, normally what happens is that if this gene gets activated or mutated, just like I told you that that proto-oncogene becomes oncogene, then there is increased amount of proliferation in the cells. That is why this lymphoma is very aggressive. And if we talk about centrocyte, then in 10 to 20% cases, in the cases of follicular lymphomas especially, what happens is that there is increased expression of BCL2. So increased expression of BCL2 already that gave rise to follicular lymphoma. But if the follicular lymphoma is kept untreated, then after that, if we get a MYC mutation again, MYC mutation again, then what happens is that the lymphoma, the malignant lymphoid cells have the power to be anti-apoptotic, but now they have also the power to be highly proliferative. And that is what helps in propagating. And that is why this lymphoma becomes very aggressive. And one more thing I wanted to tell you, that the diffuse large B cell lymphoma is one of the most common lymphomas, or probably the common non-Hodgkin lymphoma in US. So this is the pathogenesis, and this model of pathogenesis, in which there is BCL6 mutation and then there is MYC mutation, we call this a double hit pathogenesis or double hit mutations, that successively two genes are getting mutated, which produces the full-fledged disease. Now if I talk about the clinical feature, then generally patient will present with a fever, anorexia, and obviously these two things are common. But what happens is that there is a rapidly enlarging mass at any extranodal site. Normally what happens is that when the patient appears to the doctor, he or she presents that in his actually what happens is that the Voltaire ring is the lymphoid tissue of the oropharyngeal tissue, you can say, which includes the tonsils also. So what happens is that the tonsils are very much enlarged. That is what the patient is presenting in the OPD, that the tonsils are very much enlarged. And also there is an enlarging mass, not only at the lymph nodes but also at the extranodal site. More commonly, this lymphoma has a very high propensity to affect extranodal site, because what happens is that it also affects the liver, it can also affect the spleen, though they both are extranodal. Extranodal sites are those sites which normally do not contain lymph nodes, or you can say lymphoid follicles are not common there, but they are not known for harboring lymphoid follicles, but they can show the clinical features of diffuse large B-cell lymphoma. And by extranodal site, I don't not only mean liver and spleen, but also the bone, testis, brain, and bone marrow. I will write this as BM, bone marrow. But bone marrow is very rarely affected. Most commonly, we see it in bone marrow. Yes, the bone is very rarely affected. Most commonly, we see it in the testis, brain, the GIT. Yes, the GIT and the skin. So that is what happens here. And yes, the prognosis is not that good for this lymphoma. We can give some therapy, but yeah, that is the medicine part. Now, if we talk about the diagnosis, so when we take a lymph node biopsy, this is how we will clinically diagnose the patient, but still we need a lymph node biopsy. So when we take a lymph node biopsy, what happens is that you see here, this is a normal lymph node. So in a normal lymph node, we see a normal architecture of lymphoid follicles, and they are well evenly spaced. I also told you, showed you the normal architecture of lymph node and how evenly spaced they are. But here you can see no such architecture. Even in follicular lymphomas and CLL, you were able to make out the architecture of the lymphoid follicles, but here there is no architecture. Everything now feels that it's just diffuse. Everything, that is what it has been called diffuse large B cell lymphoma, because you are not seeing any follicles at all. But why we were able to see a kind of a follicular architecture in CLL and follicular lymphoma? Well, that was because these lymphomas were slow growing and they took their time, and that is why the follicular architecture was maintained. But here the follicular architecture is not maintained, because first of all, this presents when this lymphoma appears, it the lymphoid or malignant lymphoid cells rapidly start dividing. They don't wait that okay, I have to maintain a follicular architecture, I will grow slow. No, they just submerge into one another. That is why you see there you can't make out any follicles. It feels like it is a diffuse kind of a growth. So that is what happens. This is a DLBCL picture, and now if we zoom this area, then we get this in microscopy. So what we are getting are these cells, these large cells, you can see. Yes, these large cells. Yes, so these large cells are what are the malignant cells which we get in DLBCL. So basically they are very large in size and they have a vesicular chromatin. Now what do you mean by vesicular chromatin? You are saying that this must be the nuclei. So the nucleus is not that dark and it feels a bit loose. That is what meant by vesicular chromatin. Now loose means that they are very much transcriptionally active. But hey, wait a minute, you told us that yes, they are transcriptionally active. By that it means that they are rapidly proliferating. See, for rapid proliferation also you need a transcription to be very much active. In naive B cells, just like I told you, that they are very transcriptionally repressed. They don't all they not only produce antibodies, but they are also do not dividing, they are also not proliferating. So that is why they are having a lot of heterochromatin. But here what happens is that after these mutations of MYC and BCL6, first of all these cells are in a undifferentiated state, and then they are also proliferating. So for proliferation also you need a lot of transcription, and that is why you see that the chromatin is loose. And also the cytoplasm is also basophilic. It does not appear eosinophilic at all. It's blue in color. And why is that? Because we are producing a lot of rRNA, ribosomal RNA, and ribosomal RNA is produced by all the cells which are rapidly multiplying. So that is why the cytoplasm appears basophilic. Now, when we talk about a bone marrow aspirate, then we generally don't take a bone marrow aspirate because the DLBCL does not produce a leukemic picture. It is very rare that it produces a leukemic picture. But if we take a gross image of the diffuse large B cell lymphoma and we see an image of a spleen here, then you can see large white structures in this. Just like I showed you in my previous videos of follicular lymphoma, that we did see some large white structures, but they were not that big. Obviously this is an aggressive lymphoma, that is why we are seeing such big structures. And if I talk about the immunohistochemistry, which is most commonly used for diagnosis also, it gives a sure shot you can say a sure shot diagnosis that yes, this is diffuse large B cell lymphoma. So we get CD19, CD20 positive, that will obviously will positive, but the most differentiating factor is that we get CD10 and BCL6 positive also. Although in some cases also we don't get CD10 and BCL6 positive, but there you will get BCL2 and M.B.B.S positive when you do molecular studies. So you will able to make out that okay, the M.B.B.S is positive, BCL2 is positive. This is sure shot that this is diffuse large B cell lymphoma, because it has a you can say several types of pathogenesis it's going through. Sometimes it arises from CLL, SLL, sometimes it arises from follicular lymphoma. So that is what I'm talking to you about. And leukemia is very rare. It rarely progresses to a leukemic picture. So that is for today now. I think I have talked about DLBCL. I will see you in my next video. Till then, bye bye.